how much it costs, how long are the waiting lists, and how long will they be away from home?
Okay, actually I am far from money because our authority, our administration is responsible for price, but this is around 45,000
Yes.
euros. And we are not private hospital, we are governmental center, and also I know that our authority is very wise, and all additional tests and treatment, and sometimes we need to use intensive care unit treatment.
Yeah.
Patient doesn't need to pay for additional expenses. So
Great.
because we are mainly research institute, if we can treat patients without money, I would be much more happier.
That's one of our questions later on, actually. So that's really helpful.
Waiting list is about, and we have schedule for April, May next year now.
Okay.
But sometimes, of course, this is a disease, unpredictable disease, and we are not in supermarket, so of course we provide transplantation based on firstly medical decision.
Yes.
If we have emergency or urgent situation with highly aggressive multiple sclerosis situation, then we can't wait till April, May. We provide additional support.
That's great, really good. And so when the patient arrives, how long are they with you for before they go home?
It takes around 1 month.
Yes.
If everything is okay, it's not so long because we provide very quick examination, only 2 days, and make decision together with patients and patient's family based on all results. So all blood tests, ultrasound, X-ray, MRI, all tests according to international rules, ready in 2 days.
Great, gosh, that's fast. Okay, now we heard you talk about this next question a lot at the conference, and the other people at the conference were talking about it as well. So which type of MS do you find that HSCT is the most successful for, and what are the success rates for progressive MS and for secondary progressive?
Yeah, it's very interesting question, and we discussed a lots of different opinions. Our opinion, we need to treat all patients with all variant MS, because of course the ideal situation is early relapsing remitting multiple sclerosis. The earlier the better, and success rate for relapsing remitting, especially for young patients for early MS, is around 95%. For secondary and primary progressive, it's about 65-75%. But it's important to know when we start to treat secondary and primary progressive multiple sclerosis, we should plan treatment not only using chemotherapy. This is complex treatment. And to be successful, we need to plan rehabilitation at home, especially in disability situation.
Yes.
So transplantation and early and late post-transplant rehabilitation under control of physiotherapists gives much more result. Of course, to compare with disease-modifying drugs, primary and secondary progressive, 70% is quite good result.
Incredibly good. I think this will really help people whose doctors are saying to them it doesn't work at all for secondary progressive and primary progressive.
It works.
To show them this. That's
works.
Great. So a lot of patients come to this treatment and expect that it's going to reverse all their symptoms. That's not necessarily what we're looking for. So what would you say to those patients who are looking for their disability to be improved?
Okay, first 3 months after transplantation are usually more difficult than other. Recovery process, high-dose chemotherapy. Our quality of life research shows that improvement starts after 6 months, after 6 months, and reach a peak to 1.5 years. And the more disabled patients, the more difficult situation, more difficult rehabilitation. We have to work much more in rehabilitation in case of disability. Of course, sometimes, especially in disabled persons, after stress, after virus infections, they may have temporary symptoms as a result of old age.
Yes.
And in each situation, we should provide examination. We should know why it is. If it's not MS related, it's temporary and short term. If it's MS relapse or progression, we need to provide MRI, neurological examination. Of course, we should help other, and we have approaches for this situation.
That's great. What has the mortality rate been at the clinic over the last 5 years?
0.2%.
Gosh, that's incredible.
0.2%.
Yeah.
Tragically, we have lost 3 patients, and we are terribly sorry, but this tragic experience helped to develop new technologies. Now we are not on one place. We use technologies to predict especially occult infection and occult inflammation. So now we know how to predict it.
And how many patients have you treated over the last 5 years?
Since 2011, for 5 years, it's difficult to say for last 5 years, as usually we treat around 220, 230 patients a year, so this is around 1,000 patients.
Oh gosh, it's a lot, it's a lot. Can you tell us a bit about the protocol that you follow and what a patient coming to you will experience day by day?
The protocol, I think this protocol is the best with with best balance, effectiveness and safety. We use 4 days cyclophosphamide based protocol. Cyclophosphamide 200 mg per kilogram body weight, and we use rituximab instead of ATG. And during our discussion yesterday, Richard Burt and colleagues proved that rituximab is much better than ATG.
That's very interesting.
So because ATG gives many complications, gives temperature, and make results worse. So also, on the other hand, we don't need to use this medication. We have result group with and without ATG, no difference. So we use rituximab based protocol, and we provide first stage stimulation and collection. Stimulation without chemotherapy, because it's also necessary, not necessary for 5 days for stimulation and collection. 4 days for 5 days for stimulation, 1-2 days for collection, 4 days for chemotherapy, then transplantation, around 10 days of isolation, and then 2-3 days for examination in rituximab infusion.
Great. What sort of complications are possible, and are there specialists in the hospital who can help with non-HSCT related complications, illness, injuries, that sort of thing?
The most common complications: diarrhea, fever, fatigue, tiredness, and of course sometimes pneumonia is very rare. Temporary neurological worsening is quite common, and mucositis, like oral cavity inflammation. But the rate of life-threatening complication is almost 0.
That's fabulous. So, and you said a little bit earlier that if there are complications that arrive or there's extra treatment, that there is no extra cost for that, it's all part of.
We have some cases where we need to send patient to intensive care unit department. It was severe infection, so of course it's expensive treatment, but patient doesn't pay for it at all. No extra payment.
Yes.
For additional blood transfusion, for additional tests, including CT scan and additional MRI and additional intensive treatment. We are university hospital, and they don't calculate money. They have fixed price.
Good.
I'm happy with it, but I would be much more happy that we can treat without
yes,
payment. But
yes, in an ideal world.
Unfortunately, in Russia we are also limited for Russian patients. We have only 20 spots for 1 year for transplantation without money, and so we have limitations.
Yes, yeah, of course. What about fertility issues? Are people likely to encounter fertility issues? Should they freeze their sperm, eggs, embryos before HSCT?
Lymphoablative protocol we use usually doesn't affect on fertility if a lady didn't have previous problems, so the risk to have infertility not more than 1.5%. But to be on the safe side, we recommend cryopreservation.
Yes, yeah. Can you tell us a little bit what the procedure of the chemotherapy is like for the patient? Because I think that's quite a concern for a lot of them. What am I going to feel like? Is it different for everybody? What can they expect?
Excuse me, what's the main idea? Could you repeat the main idea?
So when the patient has chemotherapy, what can they expect? How will they feel, or is it different for everyone?
Sorry. We use very strong protection. We use anti-nausea, enough hydration, urine bladder protection, including urometixan. So usually the most common side effects: sweating and fatigue and lack of appetite and so on.
Okay. What we're finding in the UK at the moment is that the GPs of the patients that had HSCT are reluctant to help them when they get back. So what sort of follow-up procedure should there be when they come back, and what should they do if they become unwell?
It's not difficult. GP or hematologist in the first 3 months is enough, and further periods, of course, in case of disability, neurologist and rehabilitation staff. But mainly early post-transplant period, first 3 months, hematologist or GP, and later neurologist. But we recommend routine blood tests in the first 3 months, and MRI 3-6 months period, and then annually. Nothing difficult.
Do you find that a lot of the patients that you treated come back to you for blood tests and return to you for their MRI and so on, or?
We support our patients, we support our friends, and if they want, they can send me all results. I am hematologist, I give comments.
Yes.
And or some patients prefer to have follow-up MRI closer to key point, 1 year period. We are happy, we provide it weekly.
Yeah, a lot of your former patients have said that, how supportive you've been. And yes, your patients that you treated always say how wonderful the follow-up is, and that you always respond to them, and how kind and thorough you are, which is great. That's what they want. Vaccinations, should patients have them before they come to see you? Will they need them afterwards? What are your thoughts on that?
We don't recommend additional vaccination or vaccination according schedule before transplantation, because it's lymphoablative protocol, and this is autoimmune diseases. We don't recommend vaccination after transplantation. Patient can be vaccinated, but for important medical reasons like rabies or against malaria, yellow fever, and vaccination is possible, but not routine, like influenza. And also, the lymphoablative protocol save previous memory, vaccination memory, so not necessary to have a vaccination. This is mainly for oncology, hematology, or allogeneic transplantation.
Okay. When patients come to this facility, are there any language barriers? Are there any problems, or will they be able to understand all the staff? How's the communication?
Anesthesia is here, also I'm here, all our doctors speak English. Sometimes we provide transplantation for patients who don't know English and like only French or only Arabic, and we use smartphone for translation.
Oh, great, yes.
But of course we have special list with symptoms. Patient may call for nurse, point symptoms, they call me any time of the day, and we solve this problem. No, usually no difficulties.
That's great. What is the maximum EDSS that you treat here? And when a patient has been treated, do you give them a new EDSS when they arrive here to make sure that it's accurate? What do you do?
We can reassess this, because our neurologists also check our patients before transplantation, but the up level of EDSS 6.5, but we make decision personally sometimes if this is 7 or 7.5, but 3-6 months ago it was quite quick progression. 3-4-6 months ago, patient was able to walk. We try to save it because we can we can improve.
Yes.
So many of our patients are heavily pretreated and disabled because they refused in many other centers.
Yes. Yeah. What other conditions? Obviously, they came up at the conference over the last couple of days. But can you tell people watching this video which other autoimmune conditions you treat with HSCT?
We treat multiple sclerosis and other autoimmune neurological diseases. CIDP is quite sensitive to transplantation. Myasthenia gravis, rare neurological condition like stiff person syndrome, but of course no one center has to have enough experience. We have 2 patients and I think maybe we will be successful. Some rheumatic diseases, systemic sclerosis, rheumatoid arthritis and lupus are not good option for transplantation. Among rheumatic diseases, and of course Crohn's disease, 40–50% we develop we develop protocol with additional using of monoclonal antibodies. We discussed it with Richard Bird yesterday, and I think we can treat it also. Neuromyelitis opticum is very difficult condition and disease. We develop protocol stronger than usually for MS to try to help these people.